Another good day, my dear postgraduate students. Welcome to Glide the Slide. I hope the picture on the screen is much more attractive than my beautiful face. Welcome again to Glide the Slide. In the last class, I had given you a history of a 55-year-old male coming with complaints of anosmia and episodes of epistaxis. And this was a picture that was given to us. Now, before I plunge further, one thing we should always think of. There is a stratified or a pseudostratified columnar epithelium, and I'm finding the cilia over here. So probably I should be able to guess the site. That having been said, there are multiple dark cells which I am seeing lower down. This could be either inflammatory or neoplastic whatsoever. But let me have some idea of it before I go further. I have not divulged the lesion so far. The introduction and gross. This term was introduced by Berger and Luke in 1924. It is a locally aggressive lesion and spreads by hematogenous and lymphatic route. It forms about 2 to 6% of the nasal tumors and can present as an obstruction or a source of epistaxis, can be mistaken for a polyp. Because grossly it is polypoidal, glistening, soft reddish. And it is hypervascularized, leading to the epistaxis. This again is another tissue. I am able to see the kidney over here, and then this is the suprarenal. Adjoining to that, there is a lesion. So, what could it be? I am able to see about sheets of these poorly differentiated cells. There is some anastomosic trabeculae, but the tumor cells are all loose. They are not even opposed to each other. And the stroma behind is somewhat hyalinized and mildly edematous. Cytoplasm is hardly discernible. And look at this one, superimpose it. I am able to see multiple rosettes, and in some cases, there can be the pseudo rosettes also. Look at this one. This probably is a pseudo rosette, and this can be the rosettes over here. And classical, undifferentiated cells. So I hope you people can guess the diagnosis. It is a rare malignant neoplasm commonly affecting the sinonasal tract. Arises from the olfactory neuroepithelium. It has got a neuroblastic differentiation and mimics a benign inflammatory lesion. Nasal obstruction, epistaxis, anosmia are all the symptoms, and it extends into the paranasal sinuses as well as can cause a facial swelling. Headache and visual field defects can be there because of compression of the nerves. So there is a lesion that is quite expansile going into the sinuses. This again is a very well depicted one. Thanks to Lisa Rupert, we shall see who it is. Positive for S and B. Islands of cells. When I see one particular region, I need not see another. It has got more or less an organoid pattern. Negative for CD99. So what can this be? And incidentally, this person I tried to trace, Lisa Rupert, is a magnificent author of the head and neck pathology, which I would like you people to kindly go to. The diagnosis is esthesioneuroblastoma. And thanks to these authors for the affiliations. Coming back to our slide, courtesy Michigan pathology. I am able to see a tumor which is subepithelial, submucosal, in nests, lobules, or sheets that are separated by a vascularized stroma. The microscopy can be described completely. You people can make a note of it. Submucosal in the form of nest, there can be lobules or sheets of cells separated by a vascularized stroma. Pseudorosettes, homocyte rosettes can be present. Palisading arrangement can be made or made out around a neural matrix, in which case it becomes almost a true rosette. The cells are uniform with sparse cytoplasm, classical, round to ovoid nuclei, and a salt and pepper type of chromatin. Nucleoli not conspicuous, and there can be varying amount of differentiation. Beautiful description thanks to outlines of pathology. Look at this. This is the salt and pepper. I hope we are able to find out something like that in the nuclei. So it has got a peppered appearance. So that is described as a salt and pepper. Cells are more or less uniform and they are having a bizarre arrangement. And this is the stroma that we have been talking about. The diagnosis can be made out by means of the CT scan, flexible fiber optic endoscope, MRI, and intraoperative biopsy after imaging studies. So it can present as a sinonasal tumor with bony erosions. Esthesioneuroblastoma. And the treatment will be surgery, external beam radiotherapy, chemotherapy, open craniofacial surgery, or sometimes an endoscopic surgery. So these are the two things. In one, I am finding sheets of cells. In another, there is a pseudo rosette as well as a rosette. I am able to make that out. But all said and done, the cytoplasm is hardly discernible. The nuclei are appearing immature, round to oval, blastemal in appearance. Hence the term neuroblastoma. And look at the entire list of differential diagnoses. Extramedullary plasmacytoma, Ewing's, one thing. Primitive neuroectodermal tumor, we should have in mind. Lymphoma is another one. And the other tumors, you people can have a list of it. At least 3 or 4 you should know, so that when the examiner gives a clue, you are able to arrive at it. The prognosis is stage dependent and age dependent. Poor prognosis in the case of metastasis, high staging and grading of the tumor. And when there is an intracranial spread, obviously the prognosis is poor. Less than 20 years and more than 50 years, the prognosis is supposed to be bad. And there is something called the Kaddish staging system. Limited to the nasal cavity, extends only to the paranasal sinus and then beyond the nasal cavity and the sinuses. So these are the 3 grades. We shall glide to the next slide. This is a slide for diagnosis, and I would like you people not to diagnose it, but to explain this slide to your juniors. And I do not know what language it is. Tapad Lane. Kindly find it. Thank you.